physiology is like the poor kid on the block. I mean, he always gets neglected in light of imaging. But if one actually looks at prognosis, physiology often beats or rather outperforms imaging in as a single and a simple and an easy endpoint. Let's look at some cases. This is the story of a 76-year-old diabetic, hypertensive, dyslipidemic with an inferior wall MI, with ECG showing usual T wave inversion, some RWMA in the RCA, elevated troponins. This is what his RCA was like, and this is what the left circulation was like. So now we have to decide the best treatment for this patient. And this is another one with another inferior wall MI. And he had ongoing chest pain, and you can see the ECG up there on top. And this is the left circulation. Mid RCA 90%, left proximal intermediate stenosis in the LAD, proximal circumflex intermediate stenosis, and an OM2 with a 90% stenosis there. Now, basically, whenever we do a PCI, chip or otherwise, this is the three things that we need to look at. Is the PCI indicated? What's the optimal strategy? And whatever strategy we have used, how do we confirm the optimal result? And since our session today is on optimization, we're going to look at this question in a little more detail. So basics of FFR we all are aware, and we're going to just look at FFR and multivessel PCI and then FFR post PCI. FFR is basically the maximum achievable blood flow in stenotic coronary artery divided by the maximum blood flow in the same artery without stenosis. It's important to remember that we are measuring pressure and not flow, and this is because this is derived by taking away the resistance from the vessel, which is not always possible, but it's the best tool that we have, and it's the one that we've been using in clinical medicine for the last couple of decades. Does angiography assess stenosis severity adequately? Does FFR-guided intervention compare with angiography-based intervention? And evidence that FFR-guided intervention is better for hard outcomes? Does it predict the natural history of coronary artery disease by itself? Can it be used to measure an endpoint during a procedure? And can we improve what we've got? We know that angiography can be misleading, and if one uses physiology routinely, this will result in reclassifying a large number or a significant percentage of lesions that we are used to seeing by angiography, including the 91 to 99% subset, including the 50 to 70% where 35% actually get reclassified, become symptomatic to becoming significant, where they were earlier thought to be insignificant. What about natural history of stenosis? This comes from the FAME2 trial, in which long-term outcomes, once the FFR falls below 0.8, actually climb up, and the MACE rates actually go up significantly. So it does actually prognosticate, and this is what it shows, the same thing in a graphical sequence. You see that when it falls below 0.8, the MACE rates actually go up. What about FFR-guided PCI? 5-year outcomes of the FAME2 actually show that FFR-guided PCI shows a better long-term result out to 5 years. Thus, the concept of FFR-guided revasc is based on well-structured and consistent RCT-based evidence and firm clinical outcome data for the last 20 years or so. Now, ideally, all coronary angiograms or just intermediate, when we should not use FFR is more important. Sometimes typical angina and ischemia on a non-invasive testing in a region supplied by a vessel with a high-grade stenosis. You have a strongly positive MPI with reversible defect in the LAD territory and a 90% stenosis in the proximal LAD. There's no need to do an FFR. Culprit vessel of a STEMI, we know that it's not really great because you can't take away the resistance of the microvasculature under any circumstances in the acute MI. If the FFR result is not going to change the treatment plan, patient already has severe aortic stenosis or mitral regurgitation requiring surgery, there's no point in doing an FFR in any case. Is there a role for FFR post-PCI? Now, this is what I want to look at. The data for this comes from the last 20 years, and this is a study which I picked up for its elegance from the bare metal stent era. Whenever the FFR was between 7.75 to 0.80, the 6-month restenosis was 29%. When the FFR post-stent was 0.96, the restenosis frequency was 5%. This is powerful data, and this was divided into multiple quartiles. And although this data is old, I think this has been reproduced by multiple studies subsequently, although we haven't really looked at them so carefully. Post-PCI fractional flow reserve actually determines how these lesions are going to behave over time, and it's a marker for continuous risk, this FFR. Out to 2022, when 1322 patients in the PROPHET FFR that was presented in the EuroPCR 2022 were divided into the control groups who were negative FFR and were left alone, Group 1 and Group 2, where the FFR was positive, the first group had at least one lesion which underwent an angio-guided PCI, and the second group had a PCI guided by FFR, with the post-PCI FFR assessment being done as well. The post-PCI FFR showed a significant improvement post-PCI as one would expect, but 12% of them required further optimization even after stenting, and there was a significant difference in the physiology-guided and the angio-guided group MACE rate at the end of an year. Target vessel revasc was also significantly reduced in the physiology-guided versus angio-guided group, and there was no significant difference seen in the incidence of MI or cardiovascular death, but revasc and major adverse events were significantly reduced by physiology-guided PCI when physiology was done at the end of the procedure. This has also been reproduced in multiple studies, the FFR search, which actually showed that 56% of patients who were treated in routine practice had at least one lesion with a post-PCI FFR of less than 0.9. That means a suboptimal result. And 68% in the target FFR had an FFR of less than 0.9 post-PCI. In a meta-analysis, it's been shown that there is a continuous relationship between the post-PCI FFR and subsequent events, with an odds ratio of 4.95 with the FFR of less than 0.9 and 7.35 if the FFR was less than 0.8. This is very, very strong figures and very difficult to argue with. These are just a summary of all the studies which have looked at post-PCI FFR, and they're the basis for the figures which I've given you. Thus, physiology post-PCI, we could look at resting, or I've just summarized the evidence there. This is taken from a JACC intervention article. If the PDPA is 0.96 for FFR 85 to 92, but 0.90 is the cutoff. You must get at least 0.90 or more. DPR of less than 0.89. Contrast FFR, there's no post-PCI cutoff available as yet because it hasn't been validated. For IFR was 0.89, and for RFR also there is no data available as yet. This is one of the algorithms proposed in 2022. That means we do a post-PCI physiology assessment. If the physiology is good, leave the patient alone. And if the physiology is suboptimal, that's when we do the imaging and go in and see whether we need to do something more, what more we need to do, whether this is because of an edge dissection, because of incomplete expansion or whatever. This is one of the simpler and cheaper ways of getting to the place where you can get an ideal PCI in a world where imaging is not available for reasons of expense or for other reasons all the while. Additional treatment thus could be dictated by what the imaging shows us, whether it's underexpansion, edge dissection, geographical mix, or residual disease. What about the patients that we showed? After we finished with the RCA and the inferior wall MI, this is the left diagnostic that we saw. This is the first patient. First, we did the FFR of the circumflex, which was actually negative. The FFR wire wouldn't cross the LED at all. The OCT catheter could not be placed in the LED. So obviously it was heavily calcified into subtotal occlusion. So we went ahead and did a rotablation for the LED. And at the end of that, did the OCT. And that showed us the thickness, residual thickness of the calcium. That was about 800 microns or so, with some significant and important good size cuts that we had made. A little bit of a lipid plaque in the proximal LED as well. We cut the entire length with a cutting balloon. Post-cutting balloon did another OCT that again showed that we had got good, nice cuts that you can see in the OCT over there between 20 and 30. The rest of the residual lumen was fine except at 40 again, where we had some more very good cuts. These are the cuts that you saw on this one, and then went ahead and finished with 2 long stents in the LED, a long post-dilatation and the OCT after the post-dilatation, which showed a good result in the lumen view. We had a little bit of underexpansion and went back in and corrected that, and then remeasured the FFR in the LCX and the LED. And we found that the LCX FFR actually didn't change. Our LED FFR had become 0.9, but we couldn't measure a baseline FFR in that. These were our final views for this particular patient. And the second patient that we saw, the circumflex looks like it has an intermediate stenosis, and the OM2 had a 90% stenosis. So we fixed the OM2 and then did the physiology for the circumflex, which was actually negative, the intermediate lesion. The LAD, which didn't look so tight, was actually 7.4, and the RFR was 8.1. So we went ahead and fixed the LAD, and then the post-PCI FFR in the LAD was 0.9 in this particular case. IVUS, we all know, there is not so much new, but we'll just quickly go over what is our current thought process. Pre-intervention, we look at the vessel, the lumen dimensions, the plaque composition, appreciation of calcium that we've spoken of. Post-intervention, underexpansion, edge dissection, geographical miss, malapposition, and intramural hematomas. Assessment of stenosis severity has been actually validated just for the left main only. We know that anything less than 4.5 needs to be done, anything more than 6 can be left, and in between we use either FFR, non-invasive, and look at imaging as well to decide whether it needs to be done looking at plaque burden, etc. LMCA stenosis can often be significantly looked at by IVUS. Ambiguous lesion morphology is one of the reasons. In fact, there's a beautiful article in JACC when about 70 interventionists from the Netherlands were interviewed as to what were the hard indications for imaging. And one of the ones on which they all agreed was the evaluation of an ambiguous lesion anywhere in the coronary tree. This is what this shows. One shows all these three have actually hazy appearances in the left main. And one is a calcified nodule, the other is a thrombus, and the third is a plaque rupture. All three look pretty similar, and it is actually imaging that gives us the answer in this situation. This looks like an ambiguous lesion, but when one puts in a lady who's got ongoing chest pain, but when one does the IVUS, we realize that she's actually got scarred both into the LAD and into the circumflex in both territories. Stenting strategies evaluation, halfway through when one does, you can decide whether to do a 1 stent or a 2 stent looking at the ostium of the side branch and the plaque burden of the ostium of the side branch. If one has an MLA of less than 3.7 and a plaque burden of more than 50%, it's actually better to do a 2 stent. This has been proven in some studies and has been reported as well. Once the plaque burden goes beyond, lesion preparation as far as calcium is concerned, we understand very well that calcium is one of the most important negative modifiers of results of percutaneous intervention. And the scoring system will tell us whether we have done enough or we need to do more as far as modification is concerned. Stent sizing, we look at the landing zones, the proximal and the distal landing zones for both the main branch and the side branch. Identify a normal segment, identify the stent diameter, identify where we need to land it, and then just go ahead and do it. These are the advantages that imaging gives us, especially with respect to IVUS. During the procedure, it also tells us whether we have completely crushed, whether we have crossed the side branch in the appropriate strut, whether the wiring has been abluminal when we have to wire the side branch again. After stenting, it tells us about underexpansion, malapposition, geographic miss, dissection, and longitudinal deformation. If you have a 90% MLA, minimal stent area, more than 90% of what the normal segment is beyond the stent, we're pretty much okay. And the 5, 6, 7, 8, which was given, I feel is a gross underestimate. Even the Excel data is actually a little less. I think it should be a little larger than that. This is what is the meaning of geographical miss. That means if you have a stent ending proximal to where the disease extends, that part needs to be covered by probably putting another stent. Edge dissection is also seen on IVUS, although it's better seen on OCT most of the time. In summary, physiology has an important role in optimization. There is substantial evidence to use physiology post-PCI, and we're actually trying to do a little bit of work in this direction. Hyperemic indices guided optimization can substantially decrease stent failure and can actually act as a gateway for the requirement of imaging post-procedure in a patient with a type A or a B1 or a B2 lesion. FFR appears valid within limits. IFR initial data is encouraging, but we need a little bit more data here. Plaque characteristics stratify risks significantly, especially calcified and lipid plaque. IVUS guidance has been proven to improve outcomes in terms of assessment. It detects landing zones, plaque morphology, stent edge health, expansion and malapposition, and post-stenting, whether we have done a good job or otherwise. More data is forthcoming, and this decision making is likely to be refined and improved with more physiology. Thank you for your attention, and I should be glad to answer any questions.
Thank you, Ajay. One or two comments from my side. One of the things which we experience in the cath lab, when you take up multi-vessel disease or complex diseases, a pre-procedure use of functional assessment by FFR, we could change the decision making at least 30 to 40%. And that, the non-region complex situations, many a time for interventionalists, it turns out to be less complex, lesser number of stents. So you can even avoid complex procedure.
Absolutely.
That is one important thing pre-procedure. Another thing, during procedure, again, the wire pressure wire could be used. Well, you find a crossover stent from left main to LED, and you find a pinch. Angiographically, it may appear that circumflex is really pinched very well. And in the olden times, you used to go for a kissing balloon inflation, sometimes. But if you could get a pressure wire put down and measure if it is 0.80 above, you can safely leave. We have data on that. That is two things. And the third thing, recently we have started doing when you use the pressure wire, keep it and then or take the pressure wire after the procedure and make a pullback and find out if the FFR is not satisfactory, make a pullback and find out
locate the problem.
Locate that. And then followed by an imaging, as you said, IVUS, and then correct it. That leads to a better results. And the third thing is that instead of hyperemic indices, now that we have the non-hyperemic indices like IFR or RFR or DFR, I think it could be interchangeable for FFR. That becomes handy for use in the cath lab. You can quickly put in the wire and then put the resting pressure measurement and what is the value at the end of the procedure. So that makes the use of physiology use is the more because of the more use of non-hyperemic pressure issues. Now my question is that you are mentioning about the physiology and the morphology, and you start doing in the cases at the end, with what finding you will leave? Will you leave the IVUS criteria alone, or will you go for the criteria which you should at post-PCI, FFR should be like 0.95 or something like that? What would you leave with? What is your practice going on?
Great comment, sir. First of all, the first point that you made about multi-vessel FFR, I think that is very, very well established. I just have one caveat, that when one makes a decision based on physiology in a multi-vessel and you defer intervention in one vessel, at the end of finishing your intervention, you must go back into that vessel and check again. That's the message which I gave in the second case which I did, that we measured the FFR to the circumflex in the beginning, we fixed the LED, and then we went back again and measured it in both the circumflex and the LED. So the multi-vessel deferral is absolutely clean, but you must measure it again, second time. And as far as the endpoint is concerned, I think the screening for the procedure can be done by the physiology very, very safely. Because if one has an endpoint FFR of anything more than 0.9 at the end of the stenting, no further imaging is required. I think that is very, very good. The problem is when you do find that it's a little less, maybe 8.5 or 8.4, and you still have unaddressed lesions distally. And as you said about the pullback, I didn't mention about it because the evidence for pullback post-PCI is not yet so strong as it is for a native vessel diffuse disease. It's still a work in progress. It's not yet validated so much. So the current recommendation is that if it's not perfect, we have to go back with an imaging to try and identify what and where the problem is. So we are not yet there with physiology to identify the location of the problem with the physiological wire in the pullback. However, for the endpoint, I think it has to be a combination of both. If one is able to achieve a physiology which is satisfactory, I think you can leave it at that time. Sometimes we have got to understand that the microcirculation is not healthy, and we will be underestimating or overestimating the problem because of inability to completely dilate or abnormality in the side branches, etc. And you have to get the best result that you can under the circumstances and back off.
Thank you. Balaji.
Ajay, since it is a chip mating, do we have any data in a patients with severe LV with high LV DP, how to handle this physiology?
So there is not much data, there is only registry-based data. The basic problem with FFR is that we are measuring the aortic diastolic pressure versus the intramural pressure. Any condition which causes the intramural pressure to go up is going to compromise our ability to vasodilate the microcirculation completely. So in an ideal world, we should be able to interrogate the microcirculation. If one has got an ability to measure an IMR, and you show that the IMR is anything less than 25, then you can say that whatever FFR I do for this particular physiology is going to be accurate. But once the LV EDP crosses 20, it is highly unlikely that the IMR is going to be anything less than 30. So it becomes very, very difficult to interpret, and in patients with LV dysfunction, it's very difficult. But in patients in whom LV dysfunction is not there, we can definitely use. That's why aortic stenosis, it's still not approved. Hypertrophic cardiomyopathy, it's still not, it's a problem. It is an ongoing problem. We don't, if we have got CFR and IMR along with FFR, we can answer that question better.
Yeah, short question, short answer.
You said post-procedure functional testing is more than enough to back off. But you did show a cartoon of an IVUS showing there is a geographic miss, which can be a substrate for a future instant restenosis. So how do you justify saying that just because functionally everything is fine, there is no need for imaging to confirm the results of the procedure?
So the screening for the post-procedure is meant for type A lesions. It is not meant for long and diffuse and dirty lesions. This was meant as a screening comment. You are going to use anything wherever you use more than 30 millimeters of metal. In an ideal world, that is the definition of diffuse is more than 20, but when you use more than 30 millimeters of length and you're not sure of your landing zones, in that case you have to use imaging. But you are safe from a population point of view, and that's the problem with modern medicine, because we're very good at determining how many of the 100 patients who undergo PCI are going to do, but the individual patient were not so good. So you are safe. You're not perfectly safe, but at least you're not going to end up with a stent thrombosis or an immediate restenosis.
Thank you. Thank you, Ajay.